This conference will now be recorded.
Okay, so continuing from where we finished last time, so we'll be talking about the congenital and the acquired diverticuli of the small bowel. The congenital, as we all know, is the Meckel's diverticulum. And if you look at the embryology of the Meckel's diverticulum, the vitreointestinal duct, also known as the omphalomescentric duct, is obliterated normally by the 7th week of gestation. There could be defects of obliteration, and they can variously present in a pathological form either as a complete unobliteration, like here, where you have a posterior vitelline duct as umbilical ileal fistula from the ileum to the umbilicus, or with a terminal mucosal prolapse as part of an intussusception. Complete obliteration, but persistence as a fibrous band like this, which could be connecting the ileum and the umbilicus, which is usually a part of the obliterated vitreointestinal artery. You can see this artery out here. Or you can have a distally patent vitreointestinal duct, where the distal patency is usually present as a vitelline sinus beneath the umbilicus. You can see this cyst, or you can see this sinus present underneath. So you've got the distal part, which is patent, so either as a sinus or as a cyst underneath the umbilicus, or a prolapsed mucosa resembling an adenoma or a polyp. So in this particular part, if there's a mucosal lining out here, it tends to prolapse out. So it looks like adenoma. And the typical feature is a child who presents in the soon after birth or in the first month after birth with a red lesion at the umbilicus, and has to be differentiated from umbilical granuloma. So that's one of the presentations. Or you can have an unobliterated middle part. So the middle part gets unobliterated, resembling a vitelline duct cyst or enterocystoma. It looks something like this. You got a cyst in between. So the terminal part has been obliterated, the proximal part has been obliterated, the middle part is left behind. And most common is what we know as the Meckel's diverticulum, which is this, has a 97% occurrence in a abnormal obliteration of the vitreointestinal duct. So that is the most common abnormality is present, and this is the proximal persistence of the vitreointestinal duct. Now, it's a blind ending true diverticulum. Why do we say true diverticulum? Because it's got all the walls of the all the layers in the wall, starting right from the mucosa, extending up to the muscle layer. So all the layers are existing out here, and normally found in the terminal ileum. It rises from the anti-miscentric border. So this is anti-miscentric border. This is a miscentric border. And very rarely it can arise from the miscentric border, but the norm is usually anti-miscentric border. And the tip of the diverticulum is free in 75% of cases, that means lying free. The rest 25, it can be attached to the anteabdominal wall or to another structure around in the surrounding areas or in the adjacent part of the bowel. Vascular supply is from, I said earlier, omphalomescentric artery, which is a branch of the ileal, which in turn is a branch of supramesentric artery. So the supramesentric artery gives rise to ileal branch, and from the ileal branch you got the omphalomescentric artery. In a few instances, it may continue up to the abdominal wall, like this. It goes up to the abdominal wall, supplying the supraumbilical part of the abdominal wall. Now, these blood vessels in the postoperative phase, as I just now told you in the last slide, they can persist as fibrous remnant, and this forms a cord-like stretch between the ileum and the anteabdominal wall, which leads to great problems. Or it can give rise to volvulus formation and could be a cause of later on development of intestinal obstruction. Now, as far as the other details of Meckel's diverticulum is concerned, the rule of two is a very handy mnemonic for remembering the details of Meckel's diverticulum. So, starting with the incidence found in 2% of individuals, 2 times more common in the males, 2 feet from the ileocecal junction, 2 inches long, and usually 2 centimeter wide base is what is desirable. Half the time you got ectopic mucosa. And in this ectopic mucosa, 2 types of ectopic tissues are very commonly present, mostly the gastric, which can be diagnosed by a technetium random scan, and a pancreatic tissue. So you can have gastric tissue or a pancreatic tissue, again the rule of 2. But rarely you can also have other mucosa, and that is duodenal, colonic, rectal, endometrial, and hepatobiliary tissues, which could be represented in the Beck's diverticulum. 2% of them usually become symptomatic, most commonly in the first 2 decades of life, and often before 2 years of age at diagnosis. When they're diagnosed for the first time, most commonly is diagnosed at the age of 2 years, right? But if you look at the decade part of it, it is the first and second decade where you have the maximum incidence of presentation of Beck's diverticulum. So that is the rule of 2 for you, starting from the incidence, the males, the 2 feet from ICJ, 2 inches long, 2 centimeter wide, and so on and so forth, right? Okay. Now coming to the clinical presentation, how does it really present? In the neonatal presentation, it includes number 1, massive hematochezia. The patient can be passing frank blood from the stool. There could be a perforation subsequent to a diverticulitis, or there could be interception starting from the tip or starting from the base of the Beck's diverticulum, and that forms the apex of the interception. So it is the edematous base of the Beck's which is not forming the apex of the interception, not the apex of the Beck's. That has to be remembered. Okay, there could be a segmental ileal dilatation, or it could be presenting as intestinal obstruction, and that also in the form of an ileal volvulus. Now, the children, toddler younger than 2 years, at this age group, it is usually a painless rectal bleed. In adults, the Beck's diverticulum presents as number 1, obstruction, but more commonly is Beck's diverticulitis with possible perforation, or it can present as a chronic ulceration as a non-specific periumbilical pain. Now, this chronic ulcers which are found in these patients usually secondary to gastric heterotrophic mucosa out here. So that is again subjected to the same physiological and pathological alterations like the gastric mucosa found in the stomach. So here also the heterotrophic gastric mucosa found in the Beck's diverticulum can present with a chronic ulceration, and that in turn presents a non-specific periumbilical pain usually in the adult age group. As part of an inguinal hernia, sac content where it's known as a Litter's hernia. So these are the presentations of Beck's diverticulum in the various age groups. Now, if you look at the investigations, a dictum is very handy to remember, and that is the Mayo Clinic dictum says Beck's diverticulum is frequently suspected, is often looked for, and seldom found. And that tells the whole story. That basically means that there is no one single investigation which can diagnose the Beck's diverticulum for you preoperatively 100% of the time. A plain skygram of the abdomen just gives you an added information in the form of whether the patient is having acute intestinal obstruction or perforation. It doesn't tell you the Beck's diverticulum is responsible for that, but that's just an additive investigation. You can do an enteroclysis, which basically means a steady, contrast study of the small bowel, where the contrast is injected with the help of a Ryle's tube whose tip has been manipulated into the proximal jejunum. And with this, you can push in a thin barium or a gastrographin, or you can do an enteric enema, which we referred to last time, where with the help of colonoscope, you are pushing in the contrast beyond or proximal to the ICJ, the ileocolic junction. So enteroclysis can help you to diagnose that. Then a CCT with the oral contrast. So you do a contrast enhanced CT scan with the oral contrast. The diagnostic rate goes right up to 47.5% of all patients, and highest rate of success in symptomatic patients and in those with adequate peritoneal fat. There the CT appears to be more informative as compared to the other group of patients. A Beck's scan could help you in those patients where you're suspecting a heterotrophic mucosa. So this is a patient who's presenting with GI bleed, suggestive Beck's diverticulum. There's strong suspicion. A CT scan is probably indicative that there may be a Beck's diverticulum. So in these patients, you do what is known as the 99M technetium per technate CT scan. M stands for molybdenum, so 99M technetium per technate CT scan, and taken up by the normal and at the same time heterotrophic gastric mucosa. So that would help you to delineate, yes, there's gastric mucosa lying in the Beck's diverticulum. So it is a preferred modality because it is non-invasive, less radiation exposure, and more accurate than an upper GI in a small bowel follow-through study. So it's more informative than a CT scan or enteroclysis. Reported sensitivity 94%, specificity 97% in children, which is a very, very good sensitivity and specificity. Anything more than 90% is good sensitivity and specificity. But it has got a lower in adults. It is low sensitivity of 62.5 and a very low specificity of only 9% and a lower accuracy of 46% adult. So basically, it tells you this more informative as far as the children diagnosis is concerned, the child is concerned, as compared to the adult. A capsule endoscopy, where the endoscope is a camera instead of a capsule which you swallow orally, and it travels to a small bowel until it comes out through the fecal route. That may help. An MRI can help. An ultrasound high resolution may help in those patients where you got a inflamed mecal diverticulum, mecal diverticulitis. They have all been tried, but with very, very poor results. A double balloon enteroscopy is a relatively new technique and can also be therapeutic at the same time. So it's got something going for it. That is, number one, it is both diagnostic and could be a therapeutic maneuver. Now, coming to the treatment, it's simple. You can go in with a laparoscope or you can go in with open entrance. The standard of care is the diverticulectomy. You have to remove the diverticulum with the wedge ileal resection at the base of the diverticulum. Now, why is the wedge required? The wedge is basically required because if you have a heterotropic epithelium or endothelium, this is going to go beyond the base. So you can do a cut like this, but that will not serve the purpose. What is going to serve the purpose is that you have to include a part of the adjacent normal ileum in the diverticulum base. So you're doing a wedge ileal resection. Now, if you find that there is narrowing in the adjacent part of the bowel or that part of the bowel is also inflamed, then you go ahead and do a ileal resection, a wedge ileal resection with anastomosis, right? So either you do a wedge diverticulectomy or you do a wedge ileal resection with the adjacent part of the proximal and the distal ileum included in the whole resection. The problem comes, this is a patient where it is diverticulitis, no problem, you have done it. The problem comes when there is an accidentally identification or accidental identification at an abdominal exploration. You open the abdomen for, let's say, some other pathology, you're doing some kind of a surgery, and you bring the bowel out on exploration, and you find there's a mucus diverticulum. Now, the option is either remove it or leave it, right? Now, what would help you to decide whether it should be left as such or it should be removed? Inflammation, yes, you have to remove it, no problem. But in a silent mucous diverticulum that you find by chance on a laparotomy, if it has got a wide base of more than 2 centimeters, leave it as such. Why? Because narrow based metal diverticulum are prone to have later on incidence of complications. Wide base, they don't. So if it's a wide base metal diverticulum, dormant in the sense there's no clinical symptomatology in the past, or the patient is not exhibiting any signs on the table of any kind of inflammation, leave it as such. If the wall is thin, leave it as such. No contributory past history, leave it as such. So the question or the to be addressed whether I should remove this metal diverticulum that I've found on routine exploration or not can be partially answered by these three, and that is the base, the width of the base, the thinness of the wall, and of course a past history which could be contributed. Coming to the second group of diverticuli, and that is acquired diverticuli. And these acquired diverticuli, they are more commonly jejunal, the miscentric side, as opposed to the Meckel's diverticulum, which is anti-miscentric. Remember, wall is thin and only mucosa, and that is why this is not a true diverticule. See, it's only the mucosal wall, so it is a false diverticule, and more commonly the jejunum part. So where is mucosa herniating from? The mucosal herniation is at the points of entry of the blood vessel. So when the mesenteric blood vessel perforates through the wall and enters into the jejunum, at that point the mucosa can protrude out. So it's a false diverticule. It's not true diverticule. It can either be solitary or it could be multiple. The problem is not a formidable problem because most of the time it's asymptomatic. But if there are multiple jejunal diverticuli, they can present with malabsorption syndrome because of pooling of food, and there is bacterial multiplication. Inflammation may occur, and if it does, then there could be a possibility of a perforation. The diagnosis again difficult, but if there are multiple, it becomes easier. Multiple divertically, the diagnosis is easier. Single divertically, very, very difficult to diagnose, even difficult, more difficult than diagnosing a Meckel's diverticulum. But the investigative maneuvers are the same. You use the same investigative profile as for the Meckel's diverticulum. The treatment variables are there. Number one, if it is symptomatic or it is incidental. That is question number one to be addressed. Again, you are doing a laparotomy, you bring the jejunum out, and by chance you find that this patient has got a solitary jejunal diverticulum or a multiple jejunal diverticulum, right? So that is the first thing. Number two, whether it is single or multiple. Number three, whether this diverticulum is occupying a short segment of jejunum or it is across a long segment of jejunum. So all these questions have to address before you can arrive at a final decision as to what is to be done. Now remember, this is basically in those patients where it is an incidental finding. If it is a symptomatic symptomatic acquired divertically of the jejunum, no problems. Remove it. You have to either with the segment of the jejunum or a large segment of the jejunum, right? But if it is a silent or incidental finding, then the question whether it's single or multiple, short segment, long segment, they all have to be considered. And what are the options available? Number one, you just leave it as such, just like diverticulum, not interfere. Or you do a resection anastomosis of the involved segment of the bowel. But if there's a long segment, let's say almost 1/3 of the jejunum is involved or half jejunum is involved, then what do? In those cases, probably you may like to conserve the bowel as a resection, leaving a part of the involved bowel and treating with antibiotics. Why? Because the longer the segment of bowel is being removed, the more the chance of having malabsorption in the postoperative period. So you may try to leave a part of the bowel behind along with the diverticulum, which is silent. But then this patient has to be treated with antibiotics. Why? Because you want to prevent the bacterial lodging in that particular diverticulum, multiplication, decay, and malabsorption syndrome. So that's a difficult question to address. You have to really decide what's to be done, what's not to be done. Now, coming to the vascular anomalies of the small bowel, and before we go on to that, let's have a look at the splanchnic circulation. One of the largest circulations acting as a capacitance or reservoir system. It at any given point of time, it is housing 20% of the cardiac output, 20-25% cardiac output. It varies anywhere from 10% to 35%. But on an average, at any given point of time, 20% of the cardiac output is in a splanchnic circulation. Splanchnic circulation does not only mean small intestine, remember, it also includes liver, pancreas, so on and so forth. That's why, because of housing 20%, it can affect the cardiac output. Now, regulation of splanchnic blood flow is important. Why? Because that has got a major effect on the cardiac return and ultimately the cardiac output. And what regulates the splanchnic blood flow? Number one, the intrinsic autoregulation, which could be myogenic autoregulation, which is mediated by the bowel wall muscles, which is stretch mediated. Metabolic autoregulation, basically by the metabolic products which are produced, namely the lactic acid and so on and so forth. Autonomic regulation. Now, this is a rapid form of intrinsic autoregulation, is a rapid form. But what is more important as far as the GI is concerned is the sympathetic vasoconstriction and the parasympathetic vasodilatation, which can again alter the cardiac return by emptying the splanchnic circulation or dilating it and leaving more of the blood in this capacitance system. Humoral and hormonal regulation also works on the circulation, and that is basically vasoactive mediators and exogenous drugs. Now, as said earlier, 20-25% of cardiac output is there in the splanchnic circulation. We all know that the gut or the GIT has 3 arteries to it: the celiac, the superior miscentric, and the inferior miscentric. Now, as far as the small bowel is concerned, it is a superior miscentric artery which is of prime importance which is supplying the duodenum, the pancreas, small bowel, proximal colon of the junction of middle, and the left third of transverse colon. Remember, when we're talking about the embryology of the small bowel or of the small bowel, we had referred to what are the parts which are being supplied by superior mesenteric, and we said right from the second part duodenum up to the junction of the left third and the middle two-third of the transverse colon. Now, there is extensive collateral circulation which protects against ischemia. That is very, very characteristic. Miscentric collaterals and collaterals which are in between the three major branches. Now, the major collateral which is working between celiac artery and the superior mesenteric artery. Why are these collaterals important? For the simple reason that any vascular mishap in the small, or rather in the superior mesenteric artery, can lead to ischemia. Now, that ischemia can to a particular extent be offset by a collateral circulation depending upon the rapidity of the block or the degree of block. So we have to know what is the collateral supply. Now look at this celiac axis. Now that is the celiac axis for you, and ultimately what do you have? You have the gastroduodenal artery coming out of it, right? So from the celiac, the common hepatic, and the common hepatic then divides into the proper hepatic and the gastroduodenal. This gastroduodenal artery is going to give rise to the two pancreaticoduodenal superior artery, that is superior anterior and superior posterior pancreaticoduodenal artery, which are going to anastomose with a branch of the superior mesenteric artery, and namely that is the inferior and the anterior and the posterior inferior pancreaticoduodenal artery, right? So the pancreaticoduodenal artery is the first branch of superior mesenteric artery around the head of the pancreas. So what we are looking at is the collateral circulation between the celiac axis and the superior mesenteric artery, the celiac artery and superior mesenteric artery, which is working around or which is lodged around the head of the pancreas in the form of anterior and posterior pancreaticoduodenal, the superior anterior and superior posterior coming from the gastroduodenal, and the inferior anterior, inferior posterior, which anastomose with the respective branches lying superiorly, are coming from the superior mesenteric artery. So you have a very good collateral circulation which can come into force or which can take care of any kind of gradual reduction in the superior mesenteric artery flow, right? So that is the collateral between the celiac and the superior mesenteric. Now, the collateral between the superior mesenteric and the inferior mesenteric. Now, you got the superior mesenteric, you got the inferior mesenteric artery, superior and the inferior mesenteric artery, right? Now, there are collaterals between these two, and we all know the marginal artery of Drummond. See, this is the marginal artery of Drummond, which is basically an anastomosis out here. There's the Drummond point where there's the junction between, I said earlier, between the lateral third and the middle two-third. This is being supplied by the branches of the inferior mesenteric. This would be supplied by the branches of superior mesenteric, namely the middle colic, the left branch, and here you got the left colic, the ascending branch. So the ascending branch of the left colic and the middle colic artery, they are basically anastomosing out here, and this anastomosis is what we know as the marginal artery of Drummond, which forms the arcade of Drummond. So this whole thing is the arcade of Drummond going from here to here, which maintains the blood supply based on even one artery if required. That means if there's anastomosis here, the inferior mesenteric can keep blood supply intact to the whole of the colon, even if you ligate the superior mesenteric. And similarly, if the arcade is there, then even if you ligate the inferior mesenteric, the superior mesenteric can take care of the total blood supply of the colon. Now, what is this arc of Ryolan? The arc of Ryolan is also known as the meandering mesenteric artery. See this vessel. Can you see the AR? Now, that is the arc of Ryolan. Now, that exists inner to the arterial arcade, which we just now talked about. And this is basically a junction between, see, this is the middle colic coming from superior mesenteric, and this is the left colic. So it is more central, connects the middle colic branch of the superior mesenteric and the left colic branch of the inferior mesenteric artery. So these are the two anastomoses which are there, which are basically working to connect the superior mesenteric and the left and the inferior mesenteric through the middle colic branch and the left colic branch. Okay. Now, what about the systemic and the inferior mesenteric artery connections? Now, if we look at the collateral between the systemic and the inferior mesenteric artery, then it is the middle rectal artery, which is the systemic circulation, and you've got the superior rectal, which is a branch of the inferior mesenteric. So you got the superior rectal branch of the inferior mesenteric, which is anastomosing with the middle rectal branch of the internal ileal vessel, which can again keep the vasculature intact in the area of the rectum if by chance you've got an inferior mesenteric artery problem. Now, what about the venous drainage? The venous drainage we all know is to the inferior mesenteric and superior mesenteric vein. As far as the small bowel is concerned, see this whole small bowel being drained by the jejunal veins and the ileal veins. See the arcades, very characteristic. Remember, we talked about these arcades last time. In the first lecture, we talked about the vascular supply and identifying the mesentery, the mesenteria jejunum. See minimal arcades and long vasa vessels, and here basically multiple arcades and very short straight vessels, right? That is how you identify that. So coming back to this, all of it is going to drain into the superior mesenteric vein, which would then anastomose with the splenic and give rise to the portal system. So we have a total drainage of the small bowel into the portal system. Now coming to mesenteric ischemia. Now if you look at the mesenteric ischemia, if you look at the classification of mesenteric ischemia, so now we're talking about a cutoff of the blood supply to the small bowel. So either it could be inadequate inflow, there's something wrong with the artery, or there is an increased wall tension. Per se, the artery is not at fault, but something has led to increased tension in the wall, or there could be a reduced venous outflow because of which the artery cannot pump the blood enough into the circulation. Why? Because the outflow tract is blocked. So if you have a reduced venous outflow, it could be any problem in the mesenteric vein, either in the form of thrombosis, or it could be a nodal disease pressing on the mesenteric veins, or it could be a pancreatic neoplasm, because remember the anastomosis or the junction between the superior mesenteric and the splenic vein, the pancreas is here. So it's occurring where? Behind the pancreas. So any pancreatic neoplasm is going to have an effect on this junction. An increased wall tension would occur in, let's say, a closed loop obstruction or the pseudo obstruction. Now, as far as inadequate inflow is concerned, you can have an interrupted or you could have a non-occlusive. As far as interrupted or occluded is concerned, it could be embolization, thrombosis, volvulus, mesenteric tears, aortic aneurysm, dissection, strangulated hernias, or it could be non-occlusive, but there is inadequate flow. Any condition of hypovolemia, the whole of the vascular compartment has collapsed. So there's not enough blood to be pumping. So what circulation undergoes the first impact. The first impact is always on the capacitance circulation. And I said earlier, one of the most important capacitance circulation after the skin circulation is the mesenteric or the splenic circulation, right? So these are some of the reasons why you can have mesenteric ischemia. Now, whenever you have a mesenteric ischemia, as far as small bowel is concerned, it can occur in two forms. Number one, it could be an acute superior mesenteric artery ischemia, or it could be chronic. Now, if we look at the acute mesenteric artery ischemia, there are four important causes. There could be the fifth is another one, which is not very important as such. They're not mentioned out here. We'll mention in the next slide. But the four important one, number one is an arterial embolization known as SMAE. It could be superior mesenteric artery thrombosis or SMAT. It could be non-occlusive mesenteric ischemia, where there's no occlusion. That is known as NOMI, like for example, critically ill patient, the cardiac failure, severe hypovolemia, the patient is on iron drops, the patient could be septic, there's synchronous infarction of other organs. So all these could be leading to a non-occlusive mesenteric ischemia, basically because there is a lot of hormonal effect on the splenic circulation, leading to probably vasoconstriction, and also at the same time a severely restricted inflow into the splenic circulation. And of course, we just now mentioned about the mesenteric vein thrombosis, and could be one of the reasons could be thrombophilia or an oral contraceptive pill, thromboembolism, a dehydration where your blood has become very thick in obese persons, inflammatory bowel disease, cirrhosis, post-operatively. So these are the major causes. If you look among all these, the arterial embolism and arterial thrombosis are responsible for 68% of the reason why you have an acute superior mesenteric artery ischemia. 16% of the time, equal number of times, you can have either a non-occlusive mesenteric ischemia or you can have a mesenteric vein thrombosis, right? Now, the incidence of acute mesenteric ischemia, supramesenteric artery ischemia, increases with older age and more common in male as compared to female. Reason is very simple to understand, and that is with increasing age, there is increased chance of arteriosclerosis. Arteriosclerosis even otherwise more common in males, and that is the reason why any kind of acute mesenteric or chronic mesenteric ischemia is more common in the old age group and in the males. If you look at the pathophysiological events, what's occurring? There's a vascular block. That vascular block leads to arterial or venous block. Hemorrhagic infarction will now occur, leading to edema of all walls, small bowel and mesentery. The fluid shift from the vascular compartment will occur two ways. Number one, into the lumen and into the peritoneal cavity, right? Leading to what? A contracted vascular compartment, further compounding the hypovolemia. Mucosal function gets compromised. Why? Because the mucus is not getting enough blood, or it is edematous, or the venous congestion. So what's going to happen? The function suffers. Compromise of function will lead to what? Translocation of bacteria, leading to septicemia and septic shock. And at the same time, because the integrity of the mucosa is in question, it undergoes necrosis and ulceration. Ultimately, there could be perforation in these patients. The extent of injury would depend upon the site of block and the extent of the vascular block. Where the vessel has been blocked, how much segment has been blocked, whether it's a partial block, total block, all these would determine the extent of the injury. If you look at the embolism, it lodges at a point of anatomical narrowing, and that is 3 to 10 centimeters distal to the superior mesenteric artery origin, and that is often beyond the middle colic artery origin. So that is the most common site for the block of a superior mesenteric artery embolism. If we look at the superior mesenteric artery, the middle colic artery has come out here. So the block usually is beyond the middle colic artery. That means the middle colic artery usually is not affected in a superior mesenteric embolization. So here it is very narrow. So that is the site 3 to 10 centimeters distal to the superior mesenteric origin, often beyond the middle colic artery origin. And it's very commonly seen with atrial fibrillation patients, acute MI, and cardiac thrombi. Found in almost half the patients, you have this kind of a history. On the other hand, the thrombosis is usually in any area of atherosclerosis, and it is more common at the origin of the superior mesenteric artery or its main branch rather than beyond the middle colic artery. So that is the difference between the site of block in an embolism and the site of block in a thrombosis. The clinical features, the classical triad. And what is classical triad? Classical triad has number one, a sudden onset of severe excruciating abdominal pain, periumbilical in nature, and progressively gets worse and worse. So it is usually in the periumbilical region, number one. At the same time, what else is happening is that there has been a sudden interruption to the bowel supply. So there is a bowel evacuation both proximally and distally. Proximal evacuation occurs in the form of vomiting, occurs in almost 70% of patients, and distal as a diarrhea in 50%. And later, you can have blood-stained stools. The third part of the triad is a history of cardiac disease, and that is would account for the reason of arterial embolization. An additional hallmark of pain, it is out of proportion of the physical findings. If you look at this patient, there will be relatively very few signs. The patient at this time, in the starting point, the abdomen will be absolutely soft. It may be just a mild guarding, but the pain is so much that you can't understand why is this abdomen not showing any signs of peritonitis or not showing any signs of guarding, which would only appear late when there is been a transference of fluid into the peritoneal cavity, leading to the generation of what? Peritonitis, because of fluid moving out from within the lumen outside. The thrombosis, on the other hand, typically presents in elderly patients with diffuse ASO disease. So in the early stage, in this group of patients, the embolized and the thrombosis of the superior mesenteric artery, there's hardly anything to distinguish between these two. But if the patient is giving a patient of history of chronic mesenteric ischemia, that will almost tell you that this patient is having a thrombosis rather than an embolization. The differential diagnosis from any other acute renal condition, the pancreatitis, the acute cell obstruction, perforation, so on and so forth. But what is characteristic, as we said earlier, is any severe pain of more than 2 hours duration with no apparent cause and minimal signs is strongly suggested. So now we know why these two things are important, the embolization and the thrombosis. Now, coming to the investigation, look at the investigation, there's hardly anything in the biochemistry to tell you that you're having a thrombosis or embolization. Just non-specific leukocytosis could be there. You could have lactic acidosis, or you can have other non-specific electrolyte abnormality. Nothing specific. Even a plain skygram of the abdomen, if it is showing absence of luminal gas or just showing features of distension, becomes non-specific. What could be specific as far as a plain skygram of abdomen or a C-seated abdomen is concerned is number one, an absence of luminal gas, and number two, what is known as pneumatosis intestinalis, which is gas in the wall of the bowel, and more commonly seen in the jejunum. So if we have a gas shown in the bowel wall or even in the portal vein or mesenteric vein, this could be a very strong suggestion that probably this patient is having some kind of a mesenteric ischemia. So one, the pneumatosis intestinalis, and number two, you can have gas in the portal vein, mesenteric vein, and absence of luminal gas are investigations which are partially contributory to the suggestion that probably this patient could be having a mesenteric ischemia. Specific investigations, number one is a mesenteric arteriography done conventionally by the Seldinger's technique. You're pushing in a catheter, the tip goes up to from the femoral root, the tip goes up to the superior mesenteric artery, and then you inject the dye there. That is the arteriography. But now what has emerged as the choice or the gold standard diagnosis of any kind of mesenteric, superior mesenteric artery, inferior mesenteric artery, vascular mishap is what is known as the emergency multi-detector CT angio, and that is the choice. A lateral view is imperative. Remember why? Because it has to include the aortic branches, all the aortic branches. So have to be visualized. A duplex scan can also be tried out. MRI could be done, MRA, or that is basically the magnetic resonance arteriogram, or you can do a diagnostic laparoscopy, which would show you that the bowel has undergone gangrenous changes. So what is the treatment? The problem is that there is no treatment for the simple reason that by the time the patient has come to you, more often than not, you can't do anything in these patients, right? Now, what at least can be tried once you made a diagnosis is immediate anticoagulant should be started, number one. Number two, you should go in for an as early as possible endovascular intervention if available and if possible. And what should you do? If it's an embolus, you go ahead and do embolectomy. If it's a thrombosis, do a stenting by trying to canalize that particular area. So that is there if possible. Surgery is possible only a very small percent of cases, and the main reason being that the diagnosis is so late that the decision to do surgery is abandoned for the reason that's not going to do any benefit to the patient. Now, if you at all are going for surgery, two things could be done. One could be a vascular surgery, some kind of a revascularization procedure, or it could be the end result of vascular mishap, which has to be dealt with surgically. And that concerns what? Removing the gangrenous bowel. So varying degree of resection can be done in these patients. Now remember, you have to have minimum 50 to 60 centimeters small bowel with normal colon, or 110 centimeters small bowel without colon, because that is the critical length which is required for sustaining the life of a patient. But if there is less than 50 centimeter normal colon or less than 100 centimeters with no colon, these patients would have to be on lifelong parenteral nutrition or home parenteral nutrition, or they may need a transplantation. So when you're going for any kind of excision, of course you have to do what is necessary, but then you at the table itself you decide in the post-operative patient in the post-operative phase what help this patient is going to require based on the amount of intestine you have left behind. So if you have left anything beyond more than 100 centimeters, whether with or without colon, you don't have to be too much worried. Why? Because the life would be sustained in the patient. Of course, he would require some kind of ancillary support. So that is first part of the surgery, and that is removing the end result, the devastated intestine because of vascular mishaps. The first part should have been revascularization of the viable bowel. If it is present, said earlier, it could be done endovascular, it could be done by an open procedure, embolectomy can be done. But a superior miscentric artery bypass can only be done by an open interference. It cannot be done endoscopically as such. And retrograde hybrid superior miscentric artery stenting can be done. And what is done in this patient is that you go distal to the block. So you got a vessel, you got a block out here, you go distal to the block, you open the artery out here, and then retrogradely you try to cannulate this particular block. And once you do this block, the block is negotiated, then it is dilated and it is stented using a balloon expandable stent. So why hybrid? Hybrid for the simple reason you're doing it by open procedure and you're doing it retrogradely. You're going beyond the block, opening the artery there, and then you're going to the proximal area. So you're proceeding in retrograde direction, right? So what you're doing is that you're trying to negotiate that particular area, and subsequent to opening it, the block has been removed, the stent is in place. Then you repair the open superior miscentric artery with the help of a venous patch, not as a primary suturing. Why? Because remember, primary suturing would always lead to some degree of postoperative vascular narrowing, and that narrowing will lead to a lot of problems. The option to revascularize patients with acute or chronic miscentric ischemia who have peritoneal contamination and no other good source of inflow of the miscentric arteries is basically a question that is to be addressed at that particular point of time. Why? The patient could be having peritonitis, severe peritonitis, at the same time he's also having a major block, and you have to decide whether you want to go in for any kind of revascularization in the presence of sepsis all around. So the decision has to be taken on the table, and a lot of variables have to be weighed for and against, but it could be tried. So in principle, you can do a revascularization, but remember, revascularization is best done in a sterile. That means there is no peritoneal contamination. If there's peritoneal contamination, you have to be on your guard before you go ahead and do a revascularization. So algorithm for the ASMI management is, if you have a clinical suspicion of ASMI with peritonitis, without peritonitis. With peritonitis, there is no choice. You have to go in for either a laparoscopy or you have to go in for a laparotomy. No problem. If there is no, there are no peritoneal signs. If there are no peritoneal signs, then you do a CT angiogram, just I told you, or you do a CT scan, just I told you, multi-detector CT angiogram, right? Now, you can demonstrate either the thrombosis of the vein or the non-obstructive, or you have the embolization or thrombosis, depending upon what form of obstruction or what form of compromise of vascular compartment has been thrown up by your investigation. Either you can go in for thrombolysis, if you have embolization or thrombosis, or you can go in for a papillary therapy, because in these cases it is usually a spasm or a non-occlusive interruption, or if there is a venous thrombosis, again here also you have to go in for a anticoagulant therapy, with starting with heparin and later warfarin. If there is no improvement or there is deterioration, ultimately it has to go in for a laparotomy, and laparotomy along with a revascularization or reconstruction of the vessel if it is possible. On the other hand, the chronic ischemia or chronic superior miscentric artery ischemia is a much rarer occurrence. Most common cause in atherosclerosis leading to either stenosis or occlusion of superior miscentric artery. Usually seen in older age group and patients who are smokers, who have diabetes, hyperlipidemias, peripheral vascular disease, hypertension, or heart or a coronary angiographic disease. So in all these patients, you have a tendency for a chronic superior miscentric artery ischemia. Now, if you look at the pattern of involvement, celiac vessel is involved almost 90% as far as our small bowel is concerned. Superior mesenteric artery is involved in almost 43%. If you look at the total artery involvement, 90% would be celiac, inferior mesenteric 56, superior mesenteric is the lowest, 43%, and these are based on individual vessel involvement. In all three vessels, you have 21% incidence of having all three vessel disease. I said earlier, older age group, that basically means 6 to 70 years and more, non-specific colicky post-perineal epigastric pain within 30 to 60 minutes. That is known as the Miscentric angina, which is very characteristic in these patients. That means you have a food and within half to 1 hour, you have this pain in the periumbilical region. Is an old patient with a pre-existing atherosclerosis, be on your guard, suspect atherosclerosis, suspect chronic SMA disease in this patient. That means superior mesenteric artery chronic ischemia. Along with this, patient may or may not be having weight loss and diarrhea. Investigations, mesenteric angiogram, conventional Seldinger's, a CT angio, MRI, Doppler, ultrasound, and of course endovascular mesenteric angioplasty or stenting or open mesenteric bypass. Now coming to the malabsorptive condition, the first is celiac, and I don't think we'll be wasting too much time on the gluten sensitivity or gluten sensitive enteropathy because we as surgeons are not too much concerned with this. There's just abnormal immune response to gluten. We all know which fragment of gluten. It is the gliadine fragment, which is the fragment of gluten, which is the responsible segment or the responsible fragment of gluten, which is responsible for the abnormal immune response in the body and ultimately generation of celiac sprue or celiac disease or celiac sprue or gluten sensitive enteropathy, which are synonymous name. The small bowel mucosal hypertrophy is occurring in these patients. They're deeper crypts. The villi have become atrophic, leading to loss of absorptive surface and brush border secretion of enzyme, all leading to malabsorption. And along with this, you have intraepithelial lymphocyte. So usually in children, they present with steatorrhea, growth retardation, adults diarrhea, gastrointestinal symptoms are predominant, and these patients keep turning up in your OPD with vague kind of abdominal symptoms until you suspect this patient will be having gluten enteropathy. And that's why it is until a very long stage. That you only target onto gluten enteropathy at a very last stage. But all these symptoms are very common with a number of diseases: the flatulence, the weight loss, weakness, fatigue, severe abdominal pain. So these are very non-specific symptoms. You can also have an extraintestinal symptom in the form of anemia, osteopenia, osteoporosis. In fact, almost all symptoms involved. You can have neurological, you can have skin disorders, you can have hormonal disorders, you can have bleeding diathesis. All could be part and parcel of the celiac disease. That's why diagnosis is concerned. The gold standard as of today is what is known as the IgA-TTG or immunoglobulin A anti-tissue transglutaminase antibody, which is diagnostic as far as gluten enteropathy is concerned. Upper GI endoscopy and biopsy becomes the ultimate histopathological diagnosis, and you have to take a duodenal biopsy, and they're graded into 5 stages. I'm not going to go to the details of that, but just remember duodenal biopsy can be taken in these patients, and that becomes confirmatory. So one, you got a serum, and number two, you got a direct endoscopic contribution to your diagnosis. As far as complication are concerned, this is where we as surgeons step in. Number one, if this patient of celiac disease presenting with acute ulcerative jejunoileitis, or there's increased risk of small bowel lymphoma, or the patient's got adenocarcinoma. So these are the complication tropical celiac sprue, and that is acute ulcerative jejunoileitis, increased risk of small bowel lymphoma, and adenocarcinomas. The treatment is simple: withdraw gluten, corticosteroid therapy, drug therapy. I'm not going to the details of this. Surgery is only required in those patients where you got an associated malignancy. Now, this is distinct from what we commonly know as tropical sprue, which is basically an infective condition, environmental factors, and coliform bacteria. The symptoms are almost same: acute chronic diarrhea, weight loss, malabsorption, nutrients. Here the treatment involves tetracycline and folic acid as compared to non-tropical sprue, and that is the celiac sprue, which responds to a gluten-free diet. Bacterial overgrowth is an important problem for us as surgeons. Now see, these are some of the scenarios where you have a solitary diverticulum, which is a non-dependent, and this is basically a diverticulum which has got a reverse kind of flow. This is a dependent, so all flows out. Everything flows out from the diverticle. Here it's a non-dependent, so it gravitates and lies in the diverticle. Or you've done a polyagastrectomy, or you got jejunal diverticulums, multiple jejunal diverticulums. This figure taken up from Lovin page. You got multiple strictures, or you've done a bypass, which you should never do. A side-to-side ileal bypass should not be done. If you do, then the food comes from here, goes here. So this becomes a blind loop. This becomes a blind loop. So these are basically the scenarios where you have bacterial overgrowth. Now, what is happening in a bacterial overgrowth? In most of these conditions, it is basically either small bowel bacteria, but more importantly, it is basically the colonic bacteria which migrate from the ileocecal area and then colonize the small bowel. So upper GI, that is the jejunal presentation, and in upper GI presentation, it's usually nutrient absorption. We know the macronutrients, the micronutrients absorbed there. So you have basically minimal effect on the protein and carbs, but fat malabsorption suffers. And so these patients will present with steatorrhea, osteomalacia, glossitis, peripheral neuropathy. And if the patient got an ileal problem, ileal malabsorption, then of course vitamin B12 insufficiency will be there. The treatment required is independent antibiotic to control the bacterial overgrowth. Metronidazole helps a lot. Ciprofloxacin, tetracycline, rifaximin, and then of course correct the surgical cause if you can. Coming to short bowel syndrome, which we as surgeons are very much concerned about. Why? Because a number of our surgeries or number of presentations of small bowel to us surgeons can ultimately lead the patient to land into short bowel syndrome. How do you define it? It's a malabsorptive condition presenting with diarrhea, steatorrhea, fluid electrolyte disturbances, and malnutrition. The risk of small bowel syndrome, when does it occur? If there is a loss of 50% or more of small intestine or less than 200 centimeters of viable small bowel. Remember this, for the diagnosis or for the occurrence of small bowel syndrome, you have to have less than 50% of your 6-meter long small bowel. 6 meter was the average, remember last time in the first lecture when we talked about the anatomy. So if you have 3 meters or less than 200 centimeters of viable small bowel, in either case, you would be having a small bowel syndrome. Now, 100 to 200 centimeters of jejunum. So if you have less than 200, if 100 to 200 centimeters jejunum, these patients would be having malabsorption, but fat soluble vitamins and vitamin B12 can be given in these patients with trace elements along with minerals. If you have less than 100, that's 60 to 100 centimeters, this patient would be needing parenteral nutrition. If you look at the 4-year survival rate of patients who depend upon parenteral nutrition, it is only 70%. So the lesser bowel that you have, the more the chances of having a high morbidity and mortality. The critical small bowel length, remember, we just now referred to that last slide, 60 centimeters intact colon, 115 centimeters small bowel with absent colon. Intact colon, if it is there with 60 centimeters, how does the colon help you? Why is so much importance given to the colon? Because the colon can adapt itself, adaptive changes occur, where apart from the usual fluid electrolytes, it can absorb the nutrients and thus is an important factor in the development of small bowel syndrome. If you look at the causes, the common cause of small bowel syndrome, either there is a decrease in the length or decrease in the function of small bowel. So we just now said less than half of the bowel remaining behind small bowel syndrome. But even with a normal small bowel, you could be having a small bowel syndrome. Why? Because the absorptive capacity or the function of the small bowel has been affected. So depending upon the age, you can have a number of causes. As far as adults are concerned, you can have miscentric infarction, the Crohn's disease, radiation enteritis, you can have tumor, trauma, and similarly, the causes slightly vary if you have a patient neonatal age group or an older child. Now, the important cofactors which are important for the final outcome are to be considered. Number one, the pre-morbid length of the small bowel. Number two, the segment of intestine that is lost, whether it is jejunum which is being lost or ileum which is being lost. Jejunum is the major absorptive surface in the whole of the GI. If that is lost, you're having more malabsorption. The age of the patient at the time of bowel loss, the remaining length of the small bowel and the colon, and of course the presence or absence of the ileocecal wall. Because ileocecal wall presence or absence is a major determinant in the occurrence of small bowel syndrome. Absorption. So basically, if we look at the function of small bowel, what is being altered? The absorption of water electrolytes, the macronutrients, namely proteins, carbohydrates, fats, and micronutrients, namely vitamins, minerals, and trace elements. Under normal physiology, see, 90% of digestion absorption of significant macronutrients is occurring at where? Jejunum. Even the macronutrients, fat-soluble vitamins, are accomplished in the proximal 100 to 150 centimeter jejunum, which tells you that the first 100 to 150 centimeter of jejunum is most important part of your GI as far as maintaining your whole sustenance is concerned. Why? Because everything, 90% of the absorption is occurring in this 100 to 150 centimeters of jejunum. Okay, whether it's a macronutrients, a micronutrient, fat soluble, trace elements, whatever, largely unaffected even after large segment jejunal excision because of adaptation of the ileum. Now, suppose if you do a jejunal excision, agreed, 90% absorption is there, but if it is removed, then ileum has to take up the function of jejunum, which it does. But it will do as far as the macronutrient is concerned. But as far as the enzymatic digestion is concerned, we can't do anything about it. The enteric hormones being produced by jejunum cannot be replicated by the ileum. The ileum cannot produce those hormones. The decrease in biliary and pancreas secretions would exist. Gastrin levels will rise because in these patients there would be a gastric hypersecretion of acid. High interleukinal acid would be there. So if you're removing the first 100-150 centimeters of jejunum, a part of your derangement of the physiology can be taken care by the adapted ileum, but it cannot take care of the total altered physiology, namely these four things, which would always suffer in these patients where the proximal jejunum has been removed. Thus, what is happening in these patients is a large osmotically active solute load of unabsorbed nutrients is usually shunted to the ileum or delivered to the ileum, which then undergoes an increased amount of hygroscopic expansion, imbibing water, the volume rises, and these patients ultimately present with diarrhea. What happens if you have ileum resection? If any part of the ileum is removed, it severely decreases the capacity to absorb water and electrolytes, which is the primary function of the ileum. But if it is specifically the terminal ileum, then two things are happening in addition. Number one, interruption of the enterohepatic circulation of bile, leading to what? A net decreased biliary salt level, ultimately leading to what? Fat malabsorption, steatorrhea, and loss of fat soluble vitamins. Because if you're blocking the enterohepatic circulation, ultimately what's going back is not going back. So ultimately the bile salt concentration will decrease. And of course, there's a loss of vitamin B12. Why is ileocecal valve important? The preservative we just now said, ileocecal valve is very important. Why? It decreases the intestinal transit. It is slowing it down, allowing more time for absorption. If there's no ileocecal valve, food comes ileum, goes into the colon. So hardly any time for absorption, so malabsorption. It also prevents the colonization of small bowel by the colonic bacteria. Then we said the colonic adaptation is very important. Why? We repeatedly been saying that if the colon is present, even 60 centimeters small bowel will do. If it is not present, you have to have at least 120 centimeters of small bowel. Why is the colonic adaptation? And what happens with the colonic adaptation? Why is it important? Number one, the water absorption by colon increased up to 5 times following a small bowel resection. Resident colonic bacteria, they have got the inherent capacity to metabolize undigested carbohydrate, supplying its own needs for the enterocytes which are found inside the colon. So they will supply the fuel source to the colon endothelium. So that is the second thing which adapted. Number three, the colon can absorb 500 kilocalories daily from these metabolites, which can then be transported by the portal vein to be used as somatic fuel source by the body in general. But there is one harmful effect of this colonic adaptation after a small bowel resection, and that is it will increase the incidence of calcium oxalate stone formation. Normally, calcium in small bowel binds oxalate, making it insoluble in colon. Agreed. The calcium is there, it will bind the oxalate, right, in the small bowel. But after massive enterectomy, what has happened? Fat has not been digested. So calcium is now binding with the free interluminal fat. So calcium is no longer available. If the calcium is no longer available, the more of free oxalate is there in the bowel. If there's more of the soluble oxalate, it will be reabsorbed back, reaches the colon, absorbed increasing amounts, reaches general circulation, and ultimately the urine becomes saturated with calcium oxalate crystals and formation of a calcium oxalate stone. The physiological changes in the body with a short bowel syndrome passes through three phases. Number one, acute phase, which is from the time of resection up to any time to 1 to 3 months. Adaptation phase, 48 hours of resection up to 1 to 2 years. And then, of course, the maintenance phase. Once the adaptation is there, now the body tries to maintain, or the intestine tries to maintain its own function. In the first acute phase, what happens? Number one, if there is ostomy, the output will increase, or there will be increased amount of fluid secretion inside the bowel lumen to the tune of 5 liters per day, even as high as 5 liters per day. See, what is important about this? If it is lost to the exterior, you can well imagine the highly morbid and mortal implications of the severe dehydration and electrolyte imbalance, which may occur if this amount of fluid is lost through ostomy. If it remains inside, suppose you've done a resection and an anastomosis, so that fluid is not being lost to the exterior. Yes, it's being hypersecreted, no doubt. But suppose you've done a jejunal ostomy, a jejunostomy, right? Now what's going to happen? That fluid is going to be lost to the exterior. And this huge amount of fluid loss will lead to severe dehydration and electrolyte and fluid imbalance. Extremely poor absorption of all nutrients and development of hypergastrenemia and hyperlipidemia in the initial stage. So as soon as you've done a resection of, let's say, the proximal jejunum or a ileum, then what is happening in all these patients would be poor absorption of nutrients, severe electrolyte imbalance. You could be having a fluid imbalance and a raised gastrin level and a increased bilirubin level. 48 hours later, what's going to happen? Adaptation now starts. And about 90% of bowel adaptation takes place in the adaptation phase, which can extend from 48 hours to 1 to 2 years. And what does adaptation involve? Number one, the enterocyte there is hyperplasia of the enterocyte, right? The size increases, the function increases, the villus hyperplasia occurs. And because of enterocyte hyperplasia, villus hyperplasia, what's going to happen? The crib depth increases, the crib becomes deeper. And because the crib depth becomes deeper, there is intestinal dilatation and intestinal lengthening occurring at the same time. So this is how the adaptation is occurring. Luminal nutrition of enterocyte is essential for any adaptation. This enterocyte has to maintain its own nutrition. So that is why what is said is that in any patient where you have any kind of intestinal surgery done, reinstitute oral therapy as early as possible. Why? Because that oral therapy is essential for supplying the nutrition to the enterocyte. Parenteral is also essential, but that is basically essential to maintain the other body function. As far as the enterocyte function is concerned and the integrity of the enterocyte is concerned, it is the oral nutrition which is most important. So try to introduce luminal nutrition as early as possible. Maintenance phase is the maximal absorptive capacity of the intestine has been arrived at, that 90%, and supplementation may still be required in the maintenance phase, either as oral or parenteral, which could be either in the form of partial or total parenteral nutrition. The presentation of small bowel syndrome, significant protein calorie deficit, PCM, weight loss, temporal fat is lost, skin changes occur. We all know that skin changes of malnutrition, dermatitis, dry and flaky skin, alopecia, brittle chipped nails, early fatigue, malaise, lethargy, peripheral edema. These are all characteristics of any starvation condition. That's what's happening in small bowel syndrome. Specific symptom of vitamin deficiency will all be there. We all know that what happens in vitamin A deficiency, the night blindness, xerophthalmia, corneal ulcers, vitamin D, rickets, tetany, vitamin E, you have paresthesia, ataxic gait, and all kinds of neurological symptomatologies. Vitamin K depletion, bruisability. Why? Because the clotting mechanism is now occurring, is being affected. B12, folic acid iron deficiency, you got anemia, dyspnea on exertion or lethargy. Specific symptoms of mineral deficiencies appear very late, and that also related to calcium and magnesium in the form of paresthesia and tetany, and critically low zinc levels, anorexia and diarrhea. The aim in small bowel syndrome is what? Diagnose the malabsorption and diagnose the cause. Why it's occurring? See if it is really there, and if it is there, what is why is it occurring? So you can find, as far as contributing factors to diagnosis of malabsorption concerned, this patient would be anemic, leukopenic. This should be having megaloblastic anemia if it is vitamin B12 deficiency, and the patient will be having severe fall in the serum albumin level. So the serum protein would be indicative, and the cutoff level is taken is an albumin level of 2.5 gram percent, that is per deciliter. That is indicator of a high morbidity and mortality. Instead, you'll be having a raised C-reactive protein. Now, this is basically a good indicator of any acute phase. This is an acute phase protein reactant, and in acute phase, instead of albumin, the liver produces acute phase reactants in preference to albumin. So you'll find a raised CRP and a low albumin level, which are together indicative of a poor morbidity and a mortality figure. Liver enzymes, especially for patients being monitored on parenteral nutrition, they have to be taken care of, they have to be monitored, and of course the electrolyte levels. The treatment, adequate resuscitation for fluid electrolyte imbalance has to be done. We're not going to go to the details of that. You know how to replenish sodium, potassium, how to replenish the fluid which is required by the patient. In addition, what specially can be given to this patient? Number one, a recombinant human growth hormone known as somatropin. Remember, it's different from somatostatin. This somatropin, which is a recombinant human growth hormone, which has both anabolic and anti-catabolic influence on the various cells. The dose has been mentioned here, you can look it up. Then teduglutide, that is an analog of GLP-2 secreted from the jejunum, and this binds to the receptors in the cell subpopulation endocrine cells, endocrine cells, and this is again leading to what? Leads to local rhythm intestinal mediators that increase intestinal can be given or should be given rather to decrease the raised gastrin level. I told you increase gastrin, increase acid level. So PPIs have to be given. Antidiarrheal agents because this patient is having diarrhea. Somatostatin analogs may help basically again by decreasing, because remember somatostatin is anti-secretory in totality. So it's going to decrease the amount of secretion on the intestine. Cholestyramine to decrease the raised level of bilirubin and bile salts. Supplementation, which may be oral or parenteral, and the parenteral could be in the form of either home parenteral, HPN, or total parenteral nutrition. Surgically, can we do something? As surgeons, what can we do? Number one, non-transplant surgical intervention and transplant surgical intervention. Transplantation small bowel has got a very good 5-year survival rate of 80%. It is a reality. It is being done clinically also. Not so much in India, it is being done abroad, and 5-year survival rate of 80%. As far as non-transplant surgical intervention is concerned, basically what is at fault? Either the bowel has been decreased in length or in the amount. So that means there has been a decreased length of small bowel remaining behind. And number two, you can either increase the length or you can increase the amount of contact between the lumen and the wall of the bowel. So retarding progress of the intestinal contents or increasing the absorptive surface. And what are the options? One, you can increase the length of the intestine by the Bianchi procedure. That means you're actually converting 1 feet into 2 feet of bowel. Intestinal tapering for dilated dysfunction bowel segment. There's a huge dilatation of the bowel, non-function. You can taper it. You can do a stricturoplasty. You can create intestinal walls. These walls will retard the onwards progress of the content, again leading to increased contact time between the content and the wall. So creation of intestinal walls. And the segmental reverse bowel segment. Now, segmental reverse basically means what? That you take a segment of the jejunum. So suppose this is the intestine, you take a segment and then you reverse it. So that means the distal becomes proximal, proximal becomes distal. So the peristaltic activity of this segment would be reverse. Food is coming from here. This segment is given reverse peristaltic activity. So this will hold up the fluid, the content for a longer period of time, and that would halt the rapid intestinal transit. But then it was also associated with a lot of gaseous distension. Why? Because that segment often acts as a physiological valve. And then you can do a serial transverse enteroplasty known as the step procedure. Transplantation, I told you, the 5-year survival rate is in the region of 80%. Just 2 slides remaining. Ischaemic small bowel disease, or known as enteritis. This is a very common situation in the surgical OT, and often we find patients coming with this. This is a segmental small bowel involvement where you find gangrene. See this part, the greenish part has undergone gangrene. It can rarely be total bowel or even colon. What is the usual scenario? Poor food hygiene, protein deficiency individual, possible periodic meat feasting, infective, especially pig. This was often found in the Europe for the first time, identified in Europe in a pig feast, and that's why the name pig bell disease. The pig bell disease, the name comes from the European experience, which was somewhere in 1940s when they in one of the feasts they ate a lot of pigs, and they ultimately landed up with having this kind of disease, which was at that time known as pig bell disease. Later on, they found that the infective organism of Clostridium perfringens type C, and this was one of the most important organisms responsible for enterocolitis or enteritis necroticans. Non-specific bacterial viral infections could be there, and rarely protozoal. So all of these could be leading to this, apart from Miscentric ischemia. Pathophysiology the same: inflammation followed by necrosis, gangrene, possible perforation, vasculitis occurs, and is more common in the monsoon season. How does it present? Initial stages just mild fever, severe diffuse abdominal pain, recurrent vomitings and diarrhea, associated water electrolyte changes. Later on, associated sepsis creeps in, abdominal distension would be there, paralytic ileus would be there, and most of the time, by the time the patient comes to us as surgeons in the emergency ward, this patient would be in either paralytic ileus or in frank obstruction. Usually, the obstruction is because of inflammatory adhesions. And the end result is, of course, perforated peritonitis and septic shock. So how do you treat this condition? Before that, you have to look for the differential diagnosis, other specific cause of ileitis, that means rule out Crohn's and a mesenteric ischemia and so on and so forth. Diagnosis, nothing contributory. It is just, rather nothing specific, only contributory. A plain skygram of the abdomen can be done, can show multiple fluid levels in the form indicating AIO, or you can do an oral contrast CCT where you can demonstrate a bowel wall edema, nothing more than that. The treatment has to be exploration, and the decision how much to remove, if to remove at all. So excision with anastomosis or excision with extravasation with delayed closure. It is always safer to extravase the damaged segment. Why? So that in the later phases, this patient will not have a chance of a bowel leak. So the morbidity is there with extravasation, but the mortality figures are much less in those suspected patients where you do an excision with extravasation as opposed to excision with anastomosis. You've done anastomosis, this patient can leak in the postoperative, right? That is why extravasation is important. This patient cannot leak. Why? Because both the ends of the bowel are out into the exterior. Complications, septic shock and enterocutaneous fistula, both of them are usually mortal and they kill the patient. So thank you. This was the third part of the lecture of small bowel. Any questions, I said earlier, you can always address to me on WhatsApp or wherever you can contact me. And the lecture, this would also be available on the net by today evening on YouTube channel, and the whole lectures are all there on the YouTube channel. Thank you for your time.
This conference will now be recorded.